seen some therapists that don't look at those compensations. Like, how do you know those compensations? Can you talk a little bit about what you should be looking at, whole body, not just movement?
So in that first 6 weeks when they're in the sling, one of the home exercises is pendulums, obviously, but the other one is...
Pendulums, what is that?
Oh, so pendulums is where there's a right and a wrong way to do pendulums. It's you dangle your arm and you use your body weight and move your arm like it's got a weight on there like a pendulum. You don't lean over and stir the pot. It's not active.
Okay.
Right.
Yeah, after this we'll take a video of how the right way and wrong way to do
I'll pop up a video
pendulums.
while he's saying it.
Okay.
So one of the other home exercises everybody gets is doing scat pinches, like against the corner of a wall or like a door jamb. Or sometimes I'll give them a foam roller and they can lean up against the foam roller and do chin tucks and scat pinch. And they can do that in the sling, out of the sling. They can do that, and that's the main one because that sets up. That's your building blocks for whenever they get out of the sling, and you start talking about compensations.
Right.
And being able to identify compensations in a patient is the number one thing that all therapists need to focus on.
I agree.
During post-op rehab because you're preventing them from building bad habits. What I tell people is once we start actively moving it, I have them stand in front of the mirror. And I'll put a line down the mirror, like just with a piece of tape or something, and have them line their nose and their forehead and their chin and their sternum and everything up with that line, and have them just do active flexion, no weights, right?
Right.
And I'm like, keep everything lined up on that strip of tape, and you'll see people. Their first compensation, it's not this, it's this. They'll tilt their head over to that side, and that's where it all begins. So it's all about head positioning. So that's why we start.
Well, and you're in a sling, and you tend to go forward and tight upper trap, everything, scalenes.
And that's why we get them out of the sling at least once a week and
to really get that good motion
right
in a good position.
Right.
So this guy that actually wanted us to do this video, so you said he's gonna be in therapy for 4 months, give or take. But then you said a year until he's getting back. Is there a point where he could come back for that next level training instead of maybe going back to maybe poor habits that he was doing with the training?
Yeah, so basically once the post-op rehab is done, say 3 months or wherever, they should be on their own, right? They should be independent. They should be doing a home exercise program every day. They should be on their own, and as long as they do it exactly that in a perfect vacuum, right, you should never have to see them again. Right, but if they start to develop compensations or they start to see like things aren't going right, and they want more PT, then in workers' comp it's a little bit different. But in the regular world with insurance, they can go back to their doctor and they can either get another referral for PT, and I've had this happen multiple times, or sometimes the referral that's good for a year. Right, so depending on what their insurance will pay for it, sometimes they can just come right back on it. But the thing is if they are coming to you for post-op rehab. And there's like a status change. Like now it's not post-op rehab, it's I have shoulder pain. Or the doctor writes the referral for shoulder dyskinesis or with pain or something like that. So it's not really it's a new thing. So then there would have to be a new referral.
My question was mainly for if you had poor habits, which might have caused the injury in the beginning, how can you maybe prevent that injury from happening again with those exercises that you still want to continue doing?
So you're exactly right. So what we said earlier about what the other thing that I do for the company is going on site. I've actually done it before with someone that had major surgery like that, and I've gone to where they work and I watch them work after the surgery.
Yeah.
And I'll write up an ergonomic assessment, right, which is basically my assessment of their ergonomics and their positioning with the chair and the table or their workstation or whatever they do. And I'll be like, that's why you tore your rotator cuff. You got to stop doing that.
Right, yeah, because how do people know that, they have the surgery, they've had an injury, and then they're going through great rehab, and then they come back and they haven't changed anything.
It's good that you have that access to do that.
Right, and so I'll tell you a story about that. I had a little Hispanic woman, barely spoke English, I forgot her name. She was like this tall. She wasn't over 5 feet high. She was like up to here to me. Anyways, she had a job where she worked in a manufacturing where she had to pick something off of a table and put it into a machine that was basically like my head level.
Yeah.
Right?
Jumping there.
And so she's like every time, all day. And that's how she tore a rotator cuff. And so I went out there and I saw it was at a very prominent big eyeglass company where they make eyeglasses. And she was taking the lenses and having to put them in a polisher machine to polish the lenses after they're cut, right? And I was watching her do this and I was like, and I went and got the manager and I was like, look, this is the problem. Give her a stool and this won't happen again. And they got her a stool.
I think they would, because that's prevention. That's what we're all about.
Right.
Stop this garbage before
and that kind of where this conversation kind of began with and it's going to end with is this all, the whole shoulder rotator cuff tear, labral tear, all this is all because something bad happened. Mm-hmm. And it was either because of a terrible accident, something bad happened, or it was preventable because of an ergonomic problem that they had at work or whatever. And so our job really is to put ourselves out of business, because if we train people well enough and we go on site and we do all these consulting things, we should prevent at least 50% of the injuries that I see on a daily basis. I'd say 50% of them could be prevented. Like a big one that we did, we didn't go on site and do this, but we had to talk to their HR, was a very prominent grocery company in Texas that we all know and love. They started the curbside thing, remember? Mm-hmm. And well, now everybody knows what it is.
Everybody does curbside. Everybody does.
Yeah, everybody does curbside.
So when they started it, though, the racks that they were using, I was getting people after people after people that had injuries because of these racks. And so my boss and my boss's boss, the VP level, they went to their HR VP people and said, "Hey, we got a problem. Like, I mean, we love the business and everything, but these people have got to stop getting hurt because this is not good."
Well, yeah, it takes them out of work, and then it takes
and
it's money out of the company and everything.
So my company talked to their company, and they did a consultation thing like that, and we recommended ways to change, and that's what they have now is the improved, less injury prone version of that. So I had a lady that tore her Achilles because the thing rolled up on the back of her foot. Yeah, like it sliced it. Yeah. Oh my God. I had a couple rotator cuff tear surgeries because of those things. Oh yeah, it was like shooting fish in a barrel.